Very warm welcome for today's session on case discussion. Today's topic is a very important and common condition of epigastric pain and mass. Now, this is a clinical summary of the patient. Madam Low, a 75-year-old lady, presented with black stools, dizziness, and lethargy for 2 months. This was associated with nausea and early satiety for a month. There was no abdominal pain, but fullness of the epigastric region on eating. She doesn't have a history of vomiting, change in bowel habit, hematemesis, or jaundice. But she reports having lost 10 kg during this period of 2 months. She used to have gastric problems for a long time, for which she took traditional medication. She is an occasional smoker and a drinker. On examination, she is pale but not jaundice. She is slightly wasted but not dehydrated. No cervical lymphadenopathy on depulpation. There's no mass palpable, and the liver and spleen are not enlarged. Now we come to the analysis of the symptoms and signs in this patient. Okay, patient is 72-year-old female elderly patient. History of melena for 2 months, dizziness and lethargy, and early satiety. This was going on for about a month now, and loss of weight of 10 kg, and she has got gastric problems for a long time. She's a smoker and a drinker. And on the examination, she was pale, wasted, tenderness at the umbilical and epigastric region, and there's vague fullness and tenderness in the epigastric region.
Okay, now coming to the diagnosis, the clinical problem in this patient is a 72-year-old female elderly woman with chronic bleeding and anemia and constitutional symptoms lethargic and significant loss of weight. And she has got epigastric tenderness. So the most likely diagnosis with this clinical problem will be a gastric carcinoma. Others include bleeding peptic ulcer and a right colon carcinoma or cecal carcinoma. The less common cases will be carcinoma of pancreas, gallbladder carcinoma, and hepatoma. Okay, the investigations for this patient were a full blood count, especially to look for the hemoglobin level of anemia, liver function test, serum amylase and lipase. The patient is also scheduled for the chest x-ray to look for metastases, which were normals in this patient. The ultrasound scan of the abdomen to rule out liver and abdominal metastases, which were also negative. She was then proceeded on with the OGDS and colonoscopy if the OGDS is normal. Then to proceed on with the CT scan if necessary. The results in this patient, hemoglobin was 8.5 grams per deciliter, and this was after transfusion of 3 units of blood. OGDS revealed a tumor in the pylorus of the stomach, 5 centimeters away from the D1-D2 junction. This was followed up with a CT scan, which revealed an irregular wall thickening at the pylorus and duodenal bulb, with a few enlarged lymph nodes in the prepyloric region. This is the N1 region. The ultrasound of the abdominal ultrasound showed a stomach wall, distal stomach, the wall is thickened with an irregular mass within it. Okay, a mass in the pyloric region. This is the endoscopic ultrasound scan, which showed another mass here, lesion in the pyloric region. This one, another view, showing you thickening of the stomach wall and an irregular mass in the stomach pyloric region. And this is a CT scan page of the patient, showing you the lesion in the distal stomach, the pyloric region here. All right. This is the stomach, and here is an irregular mass in the stomach. Okay, this is another view showing you the carcinoma in the tumor in the pyloric region and the distal stomach. Here, this is the duodenum, this is the stomach. Here, another picture to show you the mass in the duodenum or distal stomach. Okay, these are CT scan films. And this is the OGDS picture showing you pylorus here with the ulcerative lesion in the pyloric region. Okay. And here another one, a similar one, showing you another lesion, the same lesion in the pylorus, causing deformity of the pyloric region here, the chronic ulcerative lesion. And biopsy of these lesions came back as adenocarcinoma of the stomach. Okay, now with these investigations and the results, the final diagnosis of this patient is carcinoma of the distal stomach, adenocarcinoma, with metastasis to the pyloric lymph nodes and one lymph node. So it's a T2 and 1 lesion. Okay, now we come to the management of this patient. Okay, this is the patient. First, we confirm the diagnosis with the OGDS and biopsy. And also, after subsequently, you go on to stage the disease with the CT scan. Okay, assuming this patient has got carcinoma of the distal stomach, T2 and N1. It's in the pylorus region. Okay, here, they shows here the pyloric region of the stomach here. There's a lesion. Okay, this is considered CA of the distal colon and probably with a lymph node in the pre-pyloric region here. So this is T2 and 1. Now, what are the treatment choices for this patient? First of all, you decide this is a resectable tumor. It's considered early tumor, so it's resectable. So number of procedures may be available: total gastrectomy, subtotal gastrectomy, and partial gastrectomy. And for this patient with a distal tumor, then you go for partial gastrectomy followed by gastrojejunostomy or Roux-en-Y anastomosis. Tumors with T3 and T4 and with distant metastasis, they are considered non-resectable. And these patients, you consider them chemotherapy, radiotherapy, and immunotherapy. Okay, in summary, we have got curative treatment will be gastrectomy, total, subtotal, or partial, with a GJ or Roux-en-Y anastomosis. And for these patients, you carry out a D2 or D1 or D2 lymph node resection. Patients who are non-resectable, you subject them to palliative treatment such as gastrojejunostomy, gastrostomy, or chemotherapy, DXD, and immunotherapy. Okay, for this patient, I said the treatment, surgical treatment will be subtotal gastrectomy because it's a distal tumor. Okay, this is suitable for tumors very distal part of the stomach, such as the pylorus, as is in this patient. In these patients, the fundus is preserved and blood supply from the short gastric arteries. Okay, the fundus of the stomach is preserved. And anastomose, the greater curvature, okay, the greater curvature is anastomose to the jejunum. And this is the gastrojejunostomy or Billrod 2 or a modified Billrod 2, it is known as your Roux-en-Y anastomosis. Okay, resection of the stomach, partial gastrectomy plus gastrojejunostomy in a Roux-en-Y fashion. This prevents reflux esophagitis. So you choose either this or this for the patient. Okay, now something about D1 and D2 lymphadenectomy in gastric cancer. Okay, these are the lymph nodes. Okay, the D1 or D1 resection lymphadenectomy is involved removal of the N1 lymph nodes. And this N1 lymph nodes is shown in this diagram. Will be lymph node groups number 1, 2, 3, 4, 5, and 6. These are known as the perigastric lymph nodes, which are the lymph nodes immediately outside the stomach. Okay, perigastric lymph nodes, and these are the N1 lymph nodes. And N2 lymph nodes are those further away, and these are the lymph nodes 7 until 12. Okay, so you have 7, 8, 9, 10, 11, and 12. And these are known as the N2 group of lymph nodes. And dissection of these lymph nodes is the D2 dissection. So D2 and D1 and D2 and D1 and D2 dissections are for early gastric cancer when the tumor is localized to the stomach. For N3 and N4 lymph nodes are when the tumor is spread further away from the tumor, and these are not considered early, they are considered more advanced cancers. Now the take-home points from this lecture. First, the symptoms and signs. Elderly patients with unexplained pallor and loss of weight, with epigastric discomfort, fullness, and a palpable mass in the epigastric region, always consider a diagnosis of carcinoma of the stomach. Also, with the patient passing melanic stools. And these patients must be subjected to OGDS and biopsy, which are diagnostic investigation, and which will give you the diagnosis of carcinoma of the stomach. Followed by CT scan, which is used for staging, and this staging is based on the TNM classification. Treatment is based on the stage of the tumor. For T1, T2 with N1 and N2, the primary treatment is surgery. It's either total or partial gastrectomy. And this is always followed up with D2 lymphadenectomy. For T3, T4 and N3 tumors, these are extensive tumors or late tumors, they need to go for palliative treatment, which consists of chemotherapy, radiotherapy, and immunotherapy, or a combination of all. Okay, thank you for your patience. Hope to see you again in another session.